Good afternoon, everyone. Today, our topic of discussion is dermatologic surgery. I am Dr. Mishkat Hamid Aziz. I'm going to conduct the topic today. So, without any further delay, let's begin. So, what is dermatologic surgery? It is also dermatological surgery, also known as dermatologic surgery, is a specialized branch of dermatology focused on the diagnosis, surgical treatment of the skin, hair, nail, mucous membrane disorder. It involves a range of procedure from minimally invasive cosmetic enhancement to the complex surgery like for skin cancer. Definition of dermatological surgery: it is the practice of using surgical, reconstructive, cosmetic and non-surgical technique to diagnose, treat conditions affecting the skin and its appendages like hair and nail. Scope in the modern dermatological surgery. First, medical or oncologic dermatological surgery is used in the skin cancer, as for example, basal cell carcinoma, squamous cell carcinoma, and melanoma. Mohs micrographic surgery is precise technique for removing the skin cancer while preserving the healthy tissue. Biopsies and excisions are the diagnostic and therapeutic tool. Second scope in for cosmetic dermatological surgery like laser treatment for pigmentation, scarring, hair removal, and resurfacing. And also there is some procedure like Botox and dermal filler. It is usually Botox are used for the face wrinkle and dermal filler on the lip. And there is other procedures like chemical peeling and microneedling, thread lifts, and lipolysis for fat reduction. Third scope is reconstructive surgery like post-cancer excision reconstruction, scar revision, grafting, and flap techniques. Procedural dermatology like cryosurgery, electrosurgery, photodynamic therapy, and nail and hair surgery. Now, advances and trends in this are use of robotics and AI in diagnosing and precision of the surgery, of the teledermatology for pre-op and post-op care, growth in minimally invasive aesthetic procedure, and personalized medicine. Approaches like target therapies for skin tumors. Now, the importance in modern practice. Vital for managing the rising incidences of skin cancer, demand for aesthetic procedure is growing very rapidly over the world, helps improving the quality of life, functioning, and cosmetic restoration. Here's a list of indication and contraindication for skin biopsy procedure, which is a very common procedure. So indication for diagnostic purpose and therapeutic purpose. Diagnostic purpose like suspected skin cancer, inflammatory skin condition like psoriasis, eczema, and lichen planus, blistering disorder like pemphigus vulgaris, bullous pemphigoid, infection of skin like cutaneous tuberculosis and deep fungal infection, connective tissue disorder like lupus erythematosus and dermatomyositis, pigmented lesions like atypical mole, lentigo, maligna, hair or scalp disorder like alopecia areata, and unexplained skin rashes or dermatosis. Therapeutic purpose comprises complete excision of the small benign lesion like skin tags, wart, and cyst, and removal of pre-malignant lesion like actinic keratosis. Contraindication of skin biopsy, absolute and relative. Absolute contraindication is patient refusal or inability to give in consent, and Second absolute contraindication is allergic to the local anesthetic like lidocaine, unless there is alternatives are available. Related contraindication like bleeding disorder like hemophilia, thrombocytopenia, patients on anticoagulant therapy, warfarin, aspirin, diuresis requires the evaluation or adjustment. Infection at the biopsy site may increase the risk of spread or poor wound healing capacity like uncontrolled diabetes, vascular insufficiency, suspected keloid-prone individuals, especially in cosmetic areas like chest and shoulder. Please note here that pre-biopsy workup may include the bleeding profile, allergic history, medication review, and also you should consider the type of biopsy, that is punch type or shape type, excisional, incisional, depends on the lesion type, size, and the location. Now we are going to explain the electrosurgery and its common application in dermatology. Electrosurgery is a technique that uses the high frequency electrical current to cut, coagulate, desiccate, or fulgurate the tissue. It's widely used in dermatology due to its precision and effectiveness in removing or treating the various skin lesions with minimal bleeding. The principle is high frequency current, which utilizes the AC current in the radio frequency range of typically 0.3 to 4 microhertz. At this frequency, this current can generate heat in the tissue without stimulating the muscle or nerve. Thermal effect, the heat produced by the resistance of the tissue to the electric current causes cutting, that is caused by cellular vaporization, coagulation, that is protein denaturation and hemostasis, desiccation by dehydration of the cell, and fulguration by superficial carbonization using spark. The various type of electrodes are used, that is monopolar and bipolar. Monopolar current flows from the handpiece, active electrode through the body and return to the pad tie with the body. And bipolar current flows from two tips of the forceps-like electrode, and no grounding pad is needed for that. And tissue intersection, this effect depends on the waveform, power setting, duration of application, and tissue type. For example, continuous waveform, low voltage, are used for cutting, and interrupted waveform, high voltage, are used for coagulation. Some implication in the dermatology: first, removal of benign lesion like seborrheic keratosis, skin tag, that is achondromes, warts, cherry angioma. Treatment of pre-malignant and malignant lesions like actinic keratosis, basal cell carcinoma by curetage and electrodesiccation, and Bowen's disease. Cosmetic procedure correction like telangiectasia treatment, milia or syringoma removal, and hair epilation. Then hemostasis during the dermatological procedure to control the bleeding from a small vessel. Advantage: it is minimally invasive, precise tissue control, and quick healing with minimal scarring when properly applied. Some precautions should be taken, like risk of burn with improper grounding when monopolar is used, and should not be used in patient with pacemaker unless the precautions are taken. Smoke plum may contain harmful particles. That use of smoke evacuators is recommended if the setting allows. Now, here's a small case to better understand the scenario. A 55 years old patient presents to you with basal cell carcinoma. Now, you have to describe the surgical techniques suitable for the excision of lesion. So, what is poking on your mind? What surgical technique would be most appropriate? Just think for a moment, and we are going to the next slide to reveal the solution. Second, you have to discuss about the postoperative care and potential complication of the procedure. When a 55 years old patient presents to you with basal cell carcinoma on the nose, function, and it is part of the face. The goal is to complete tumor removal and preservation of the nasal structure and appearance. So, surgical techniques suitable for excision. First, number one is standard surgical excision. That is, lesion is removed with a predefined margin, normal tissue, and procedure in nodular basal cell carcinoma with well demarcated borders, procedure epileptical or circular excision with primary closure and reconstruction, followed by the histopathology when the sample is sent to the analysis for confirming the diagnosis and clear margins. Now the popular technique, micrographic surgery. It is a stage excision when there is thin layer of tissue are removed and examined under the microscope in real time until no cancer cells are detected. Best for recurrent or aggressive basal cell carcinoma, ill-defined border, and lesions in cosmetically sensitive area like face and nose. Advantage is high rate of high cure rate, that is 99%. Tissue sparing technique ideal for the nose. Curettage and electrodesiccation, tumor is scrapped with a curette and the base is destroyed using the electrosurgery. Best for a small superficial basal cell carcinoma on non-cosmetic area, and not ideal for nose due to the high recurrence and potential for poor cosmetic outcome. So in cosmetically non-significant area, curettage and electrodesiccation is a good option. Cryosurgery or laser surgery is rarely used on the nose due to the lack of margin control and risk of disfiguration. Excisional biopsy followed by the definitive surgery, sometimes performed when the diagnosis is uncertain or to determine the depth and subtype before the definitive treatment. Now, what will be the postoperative care and potential complication? Postoperative care is almost same for different procedures. So I am presenting it as a case, so you have you get an idea about how you treat postoperative cases in various surgical procedure of dermatology. First, you have to think about wound care. You have to keep the site clean and dry for at least 48 hours. Apply the prescribed topical antibiotic cream, mifepristone or fusidic acid. In CVSS, you can give also oral antibiotic, and gentle cleansing and dressing changes should be advised. You suspect the procedure will be painful on the site you performed. Usually mild to moderate acetaminophen or NSAIDs are given for short duration of 3 to 4 days. And activity restriction is important to avoid the extraneous activity, bending, heavy weight lifting for a few days to prevent the bleeding or any swelling. Usually wound checkup is done in the 5 to 7 days. Suture removal for the nose is done in 5 days for nose to minimize the scarring, and monitor for recurrence at regular dermatological visit. Scar management, you can use silicone gel or sheet and sun protection to prevent the hyperpigmentation. So what are the potential complications you may encounter during the dermatological surgical procedure? Immediate complication may be bleeding or hematoma, which can be managed by the bipolar diathermy or compression technique. Infection, it is a little bit complicated procedure if you do not maintain the sterility during the performing procedure. And pain and discomfort is very common. Delayed wound healing is another complication. Intermediate complication is poor cosmetic outcome like notching, asymmetry, contouring, irregularity, etc. And hypertrophic scar or keloid formation rarely happens in the nose. Long-term complication like tumor recurrence, higher with incomplete excision and aggressive subtypes, and nasal distortion if significant tissue was removed. Sometimes due to the excessive curettage or cutting, there may be sensory changes and there may be temporary numbness. Now we are going to describe the surgical and non-surgical technique for malignant melanoma. So what is malignant melanoma? Malignant melanoma is a serious, potentially life-threatening form of skin cancer that origins from the melanocyte. The pigment cell and treatment on the days located in the mainstay of treatment, especially in the early stage of melanoma. Surgical techniques like wide local excision. Tumor is removed with a margin of skin, ensuring all the cancer cells are removed. And margin depends on breast flow thickness, that is in situ like 0.5 to 1 centimeter, less than 1 millimeter to 1 centimeter, second grade, and 1 to 2 millimeter to 1 to 2 centimeter, third grade, and 2 millimeter to 2 centimeter is fourth grade. Goal is to achieve the clear histologic margin to prevent the recurrence. And another thing we do in malignant melanoma is sentinel lymph node biopsy. So it is indicated when the tumor is more than 1 millimeter thickness with ulceration, high mitotic the first like. So if there is not found positively, complete lymph node desiccation may be also considered to remove any suspected metastasis. And in case of any accompanying lymphadenopathy, you should do lymphadenectomy, complete removal of the lymph node in the areas if metastasis is confirmed. More likely to be used in the regional disease. Reconstructive surgery may be required for large excision, particularly on the face or extremities, using the screen graft or local or regional flap. Non-surgical treatment option is used for advanced metastatic or inoperable melanoma or as adjuvant therapy after the surgery. So what are the immunotherapy? This is the main systemic therapy used, that is checkpoint inhibitor, NTPD1 inhibitor like nivolumab and pembrolizumab, anti-CTLA4 inhibitor, that is lipimumab, and boost the immune system ability to recognize and destroy the melanoma cell. It is used in specifically stage 3 or 4 melanoma. We have described the staging, breast low staging, and high risk melanoma. You should advise the oral therapy after the surgery. Targeted therapy for patient with BRAF mutation, 40 to 50% of melanoma patient usually presents with this. Drug used in BRAF inhibitors, that is vemurafenib and davarafenib. Amic inhibitors, that is tramitinib and cobimetinib, often used in combination for better result. In South Asian countries, we usually do not go that further, but in London, I have seen using these things. Radiation therapy, not the first line treatment for primary melanoma, but it is used for palliation of metastasis to brain or bone, and adjuvant therapy if lymph nodes are involved. Chemotherapy nowadays rarely used. Previously started for advanced melanoma, but now largely replaced by the immunotherapy. Drugs used in this is dacarbazine and temozolomide. May still be used in some selective cases for clinical trials, but not commonly used nowadays. Clinical trials offer access to the cutting-edge treatment, especially for advanced or refractory melanoma, and may include the novel immunotherapies, vaccines, or combination regimen. Treatment by stage, when it is stage 0 in situ, white local incision, stage 1 or 2, white incision plus lymph node biopsy, sentinel lymph node biopsy. Stage 3, when excision plus lymph node biopsy or lymphadenectomy with adjuvant immunotherapy. And stage 4, systemic therapy, that is immunotherapy or targeted, and also advise the palliative care. Please take a screenshot of this slide because this is the summary of discussion. Now we are going to discuss a little bit about the sentinel lymph node biopsy in management of malignant melanoma. By sorry, interruption, my kids. Um, the sentinel lymph node biopsy plays a critical role in staging, prognosis, management of malignant melanoma. It's not a therapeutic procedure, but itself helps to guide the further treatment decision, especially in clinically significant node negative patient and no palpable lymph node. Sentinel lymph node biopsy is minimally invasive surgical procedure used to identify, remove, examine the first node, that is sentinel node, that cancer cells are most likely to spread from the primary tumor. And it is usually hard and swollen compared to the other surrounding nodes. Purpose and rationale is melanoma usually spreads to the lymphatic system before reaching the distant organ. So the sentinel nodes is the first node to receive the drainage from the tumor site. If the sentinel node is free of cancer, it is very unlikely that the other nodes are involved. Helps avoid unnecessary full lymph node desiccation, reducing the complication. So, indication of SLNB in melanoma is according to the guideline of AGCC and NCCN, recommended for tumor feature and indication like tumor thickness more than 1 millimeter, indication is yes, and tumor thickness 0.8 to 1, consider especially with ulceration of high mitotic rate, less than 8 millimeter, not routinely recommended unless there is high risk feature present. So the procedure overview is like preoperative lymphoscintigraphy, a radioactive tracer is injected around the tumor site to map lymphatic drainage. Surgical removal, that is sentinel nodes, are identified and excised, and histopathological analysis like standard microscopy and immunohistochemistry. And interpretation of the result is negative SLNB, no evidence of local lymph node spread, no further lymph node surgery needed, and lower risk of recurrence. When this is positive, that is indicates there is micrometastasis and guides the upstaging to the stage 3 of the tumor. That may lead to the consideration of complete lymph node desiccation or adjuvant immunotherapy and close surveillance monitoring. Recent updates and evolving role in completion of the lymph node desiccation is no longer routinely recommended after a positive assessment due to the trial like MSLT2 showing no survival benefit but increased morbidity. And emphasis has shifted to surveillance, adjuvant therapy, etc. Advances of SLNB if and minimally invasive with low application rate and predictive of overall survival and disease of the free survival. There are some limitation and risks like false negative tumor may bypass the sentinel node, seroma, infection or lymphadenoma, not usual in patients with obvious nodal or distal metastasis. So to summarize the discussion, the role of SLNB in melanoma management, identify the micrometastasis in lymph node, accurate staging of tool for localized melanoma, determines the needs of adjuvant therapy, avoid unnecessary complete node desiccation. not therapeutic alone. Users guide to next. Now we are going to discuss about another procedure called cryotherapy. Here's the detail of this cryotherapy in dermatology. What is it? Cryotherapy involves the application of liquid nitrogen, that is minus 196 degrees centigrade, to freeze, destroy abnormal or diseased tissue. The result in cell death via ice crystal formation, disruption or blood supply, subsequent inflammation, sloughing of the treated area. Procedure step by step. First, the preparation. Clean the area with antiseptic. Local anesthetic is applied. Rarely needed, but may be considered for sensitive areas or sensitive patient. Patients informed about the possible side effect, blistering, pigmentation change. Application method: cotton tippet application for small superficial lesion. Cryospray, most commonly used, allows precise delivery. Cryoprobe, used for deeper lesion with direct contact. Techniques: first, freeze thaw cycle is typically used. The lesion is frozen until 1 to 2 millimeter margin of surrounding normal skin is also frozen. The area is allowed to thaw spontaneously or by warming, and then refrozen. 1 to 2 cycle is done depending on the lesion type. Duration of freeze depends on the lesion. Actinic keratosis, usually 5 to 10 seconds. For warts, 10 to 30 seconds. Basal cell carcinoma, if superficial, that is 30 seconds to 1 minute. Indication for benign lesion like skin tags, seborrheic keratosis, viral warts, molluscum contagiosum, then lentigens, that is AZ spots, and premalignant lesion like actinic keratosis, Bowness disease in situ of squamous cell carcinoma in selected cases, and selected malignant lesion like superficial basal cell carcinoma when surgery is not an option. Low risk SCC in situ for patient unsuitable for surgery. Contraindication, absolute contraindication, lesions requiring the histopathological diagnosis of uncertain diagnosis, and suspected invasive or aggressive skin cancer. Then cold intolerance condition like cryoglobulinemia, anemia, and cold urticaria, Raynaud's disease, paroxysmal cold hemoglobinuria. Relative like dark skin tone, circulation or vascular possible with deep or prolonged freeze. Never damage in sensitive areas like finger, face, but rarely possible. Post-operative or post-procedure care is keep area dry clean for the 24 to 48 hours. Blister may form but should not be popped, and mild pain can be managed with paracetamol, or even severe pain you can give NSAIDs. Healing typically occurs in 1 to 3 weeks depending on the lesion and its depth. Summary of the procedure aspect and description. Modality is liquid nitrogen minus 196 degrees centigrade and commonly used. Indication for warts, actinic keratosis, seborrheic dermatosis, superficial basal cell carcinoma. Contraindication in case of uncertain diagnosis, cryosensitivity, and invasive cancer. And advantages: it is quick, low cost, no suture, minimal requirement, and cheap. Limitation: no tissue for biopsy, pigment changes, and recurrent possible. Treatment of precancerous condition like actinic keratosis. Treating is important because it's paracetamol skin lesion. A small percentage of AK can progress to squamous cell carcinoma if left untreated. Actinic keratosis can caused by the chronic sun exposure, appears as rough, scaly patches on sun-exposed area, face scalp, often in the older adults, skin may be single or multiple lesion. Please hold on a second. তোমরা কি বের হবা না আমি বের হব? তোমরা বের হবা না আমি বের হব বলে দাও না। নাটক কেন করতেছো? ঢুকার সময় মানা করলাম তারপরও। Sorry guys, sorry for the interruption. So we are now going to discuss about the precancerous condition like actinic keratosis. Treating the actinic keratosis is important because it's precancerous skin lesion and can turn into a malignant condition. A small percentage of actinic keratosis can progress to squamous cell carcinoma if it's remain untreated. Actinic keratosis is caused by the chronic sun exposure, commonly appears on the white skins. Appears as rough, scaly patches on sun-exposed area, face, scalp, forearms, and hand. Often in older adults with fair skin that I mentioned earlier, and maybe single or multiple lesion. Goal of treatment is to eliminate the visible and subclinical lesion, prevent the progression to invasive squamous cell carcinoma, improve the cosmetic appearance. Treatment option for actinic keratosis. The treatment option is based on number of lesion, location, patient preference, cosmetic consideration, and risk of malignancy. Lesion-directed therapy, best for few isolated actinic keratosis. Cryotherapy, quick and effective. Liquid nitrogen freezes and from the blister scab healing. Good for individual with thick actinic keratosis. Pros like simple, fast, and cost-effective, and concise hypopigmentation sometimes happen, and no tissue for the biopsy remains here. Curetage plus minus electrodesiccation. This is a scraping of the lesion with curette and may use the electric cautery afterward. Both hyper or thicker actinic keratosis. Laser therapy is also used in actinic keratosis. Carbon dioxide laser is used, which vaporizes the superficial lesion, and usually for cosmetic or multiple actinic keratosis. Now, the field-directed therapy, it is best for multiple widespread actinic keratosis, especially on the face and scalp. And topical 5-fluorouracil chemotherapy cream can be applied for 2 to 4 weeks. Causes the intense inflammation, redness, peeling, and effective for visible and invisible actinic keratosis. So topical, you can see the 5-fluorouracil is an option. And imiquimod cream, that is Eldara and Zyclara, which is an immuno response modifier, especially stimulates the local immune system and applied for 2 to 5 times per week for several weeks, usually 6 weeks. And it is less inflammatory than 5-fluorouracil. Diclofenac sodium 3% gel is also used as NSAIDs that inhibits the COX-2 involved in AK development, and milder reaction usually used in population for 60 to 90 age group. But it is less effective than the 5-fluorouracil or imiquimod. Now, the Ingenol mebuted gel, which is limited use due to the side effect. It is a very short course for 1 to 2 days topically used, rapid inflammatory response, and lesion clearance. But it is not recommended to use it is unless the condition is very severe. Now, the photodynamic therapy combines a photosensitizing agent like aminolevulinic acid with blue or red light. Selectively destroy the precancerous cell and excellent for the face, scalp with multiple actinic keratosis. And minimal scarring and treats the large area by this procedure, but the limitation is it can be painful during the treatment and light sensitivity for 48 hours. Additional measures should be taken for the sun protection by daily broad spectrum sunscreen of SPF more than 30, regular skin checks every 6 to 12 months, depending on the history. And patient's education is very important to avoid the peak sun, wear hat or using the umbrella, protective clothing, regularly using sunscreen, etc. Now, to summarize the discussion, you can see which one is best for which and which is the benefit and limitation. Cryotherapy is used for few lesions. It is fast and effective, but pigmentation chance. 5-fluorouracil used for field therapy, high clearance rate, but there is inflammation and comfort. Imiquimod is field therapy, stimulate the immunotherapy and local irritation. Diclofenac mild keratosis, well tolerated and slower response. And photodynamic therapy is used in the face and scalp, cosmetically superior, but it is expensive and there is slight sensitivity. Curettage, thick actinic keratosis, we use the curettage. Benefit is we get the biopsy possible, and limitation is there is minor scarring. Please take a screenshot of this slide because it's a very summarized thing you get about the idea of these procedures. Now we will discuss a little bit about wound healing and scar management, which is a very important aspect for post-surgical and trauma wound care, especially in cosmetically sensitive areas. Among the most commonly used treatment, the silicone sheet and topical injection of corticosteroid, both backed by the clinical evidence. Now, silicone sheet or gel, what are they? These are thin flexible sheet or gel made of medical grade silicone applied directly over the healed wound area of scar. Once reepithelized and used for the hypertrophic scar and keloid and to prevent the abnormal scarring. How they work? Exact mechanism is not fully understood, but it is thought that they hydrate the scar tissue, regulate the fibroblast production and collagen synthesis, and reduce the capillary activity, that is less redness, and improve the scar pliability, height, and color. Indication for this treatment is hypertrophic scar, keloid, post-surgical wound, or burn scar. Uses guideline is to apply it for 12 to 40 hours per day for at least 8 to 12 weeks, can continue for up to 6 months, and can be reused after washing. Silicone is alternative for hard to cover area like face and joint. Benefits are non-invasive, widely available, well tolerated, even safe for the children and adult, and compatible with other therapy. Limitation is requires long time consistent use, may cause mild itching or sweating. Corticosteroids use in this procedure like type and root, topical corticosteroid and interlesion steroid injection. Topical steroid for superficial inflammation and interstitially triamcinolone acetonide analog, directly into the thickened scar. Mechanism of action, it acts by reduces the glycoamide production and inhibits the fibroblast proliferation and decrease the inflammation and capillary dilatation. And flattens and softens the latent hypertrophic scar or keloid scar. Indication, usually hypertrophic scar, sometimes used for prophylactically after the surgery in keloid-prone individual. Injection protocol usually every 4 to 6 weeks. Usually we give 4 weekly, and dose is around 10 to 40 milligram depending on the thickness of the scar. Often combined with the lidocaine to reduce the pain. Sometimes it's not needed, sometimes it's needed. It is the benefit of this procedure is fast reducing the scar in bulk, may prevent the recurrence when used in keloid excision, can be used with silicone pressure therapy or surgery. Limitation, skin atrophy, hypopigmentation, telangiectasia, and recurrence if it's stopped soon. And pain during the injection is sometimes complained. And Another thing is, just a second. So these are all about today's discussion regarding the dermatological procedure. We have tried to cover the excision, biopsy, sentinel biopsy, then wound like interlational steroid therapy, silicone sheet, then melanoma, what we use, for basal cell carcinoma, what we do, for what laser is used. We have tried to cover as much as possible in our given time. So if there is any confusion or question, you can tell me. I'm here to answer.
सर मिश्कर सर मैं
Yes.
कुछ पूछ रहा हूँ सर
Yes.
ये जो हम लोग
जी।
इंटरनेशनल जो स्टेरॉइड सर देते हैं ट्राइएम्सिलोनल एसीटेट तो सर हम लोग यूजुअली किलोवाट में देते हैं इसको हाइपरट्रोफिक स्कार में नहीं देते क्या सर इट इज देयर एनी इंडिकेशन इन हाइपरट्रोफिक स्कार एंड is there is good role effect after injecting
okay, good question. Actually, commonly used in the keloid, that is true. Keloid are very small, but personally in my practice, I have given in a hypertrophic scar and it actually works. But you know, if the scar is distorted, disconfigured, like a burn scar, then you should not go for it. But if the scar is circumscribed, like there is a cut injury and there is a swelling scar, like you can imagine like a big keloid, in that cases you can use it.
and sir and every time it is combined with lidocaine or not sir?
No, lidocaine is actually not required. In some places they use lidocaine. I actually directly inject it, and you can use the topical lidocaine spray, not mixed with the triamcinolone acetate, because it will increase the bulk of the medicine and decrease the concentration.
Yes sir, yes sir. So I generally use
lidocaine spray or lidocaine gel.
triamcinolone acetate sir. Yes sir, not
Yeah.
mixed with lidocaine. I use lidocaine gel applying.
Yeah,
before
that is
giving
right. Lidocaine gel or
5 minutes.
spray, which is good.
Okay sir, kindly share your first page sir. First page. I was
First page.
on
Okay.
first
Okay.
page. No? First page.
Yeah.
Sir, then second page sir, please. Second page.
Yeah.
Sir, third and then third page sir. Yes sir. Sir, very much informative. Today's session very much informative. Okay sir, thank you sir. Thank you sir.
Okay.
Okay.
So everyone else have any question? I guess no one else.
No sir, no sir.
Okay, so thanks everyone for
Thank
patience
you.
hearing, and again, good afternoon. Take care. See you next time. Bye.
Thank you sir. Thank you.